So, may we then move on to item 6 on the agenda, which is the NHS performance report. I'm going to, I don't know whether Simon would wish to introduce it, but then I'll ask Barbara and Paul to speak to it. Right, Barbara.
Thank you, Chairman. And the report contains two sections, really. The one about the performance of the NHS in terms of patient care and activity, and then about finances. So I'll hand over to Paul to do the finances, perhaps, and then before the discussion. I think that this report is an opportunity for the board to look at the key markers on a range of indicators about patient care, and for the board to be assured that everything is being done to make sure that patients get care across the huge range of aspects where we all know that performance is really important to patients and makes such a difference. It's what we present here are not the only indicators, and there are a wide range of other things not in this report, but we do use this report to pick out some of the very high-level indicators which are of the most importance, and I will then go on to explain some of the things that we're doing in order to make sure that we have all the actions in place to make sure that the performance remains consistently, and in fact is improved in some areas on the performance that we're seeing at the moment. I think it is important to recognise that the standards that we talk about in here cover patient experience, outcomes across a number of clinical areas where other colleagues may wish to comment, things such as friends and family tests, some of the issues around GP services and access to those, particularly some of the clinical outcome indicators. But I would like to just spend a little bit of time focusing on some of the issues which the report draws out about performance of some of the main constitutional standards, and those are the standards that patients are entitled to in terms of how long they wait for a huge range of care. These constitutional standards are critically important for two reasons. One, because we know how important it is for patients, whether they need an ambulance urgently, whether they're waiting for a diagnosis, whether they're waiting for cancer treatment, but also because it's a key hallmark of the mandate for NHS England to deliver those constitutional standards on patients. And I will focus on that because over the last few weeks we have seen a number of these indicators, these markers, not quite being delivered to the standards that we expect. And I would focus particularly on the times that our patients are waiting both for treatment for planned care and for treatment for urgent care. I think it's also really important to remember that particularly with the waiting for urgent care and the A&E waits, this is not only a marker of what's going on in our accident and emergency departments. People often say that the time patients are waiting in the A&E department is a barometer of the pressure in the urgent care system. And of course, the pressure in the urgent care system is often also what happens when our planned care isn't working as well as it might. So I think that, again, when we focus on things like what's going on in our accident and emergency departments, it is really important to remember the impact that things like access to primary care, access to mental health services, and a whole range of other things can have, because what inevitably happens if those services aren't good, patients understandably become more ill than they otherwise could have been, or turn to A&E for a service because they can't get it elsewhere. So I think it's really important to see this in the context of the much wider performance of the NHS in delivering services, the right range of the patients, the right range of services, which preclude the need for urgent care in the emergency setting, except for when it's absolutely essential. So we have seen across the board that over the last few weeks we haven't had as good a performance on the accident and emergency targets, as the 4-hour targets, as we would have expected. And that says that 95% of our patients should wait no more than 4 hours to complete their treatment. Often people think this is how long patients wait to be seen in A&E. It's not. It's the wait for the completion of your treatment, whether it's an admission or whether it's discharged home. And again, we know that the patients who tend to wait the longest are those who are waiting for admission, which is why, again, this is a barometer of our patients sometimes at our hospitals are being full and struggling to find the beds for those patients. And we know that it's not a good experience for patients not to be admitted to a bed as soon as they know that they need it. Focusing on that one, and alongside that one, obviously, comes the ambulance service. And again, we have seen over the last few weeks that the times, that the standards we set for our ambulances, of the number of patients who should be have an ambulance attend them in a certain length of time, are just marginally below the standards we would expect to see. So on the one hand, I want to reassure the board that these numbers are small. On the other hand, it's not acceptable. We want to deliver all our patients the very best service, and the standards have been set in order that we would meet the targets. So we have a range of things in place across the emergency care system in order to get this back on track. There are two phases to this. Bruce may want to comment on the longer-term phase around the urgent and emergency care review, which is about a redesign of the system in order to make it better for patients altogether. The other aspect, of course, is the short-term focus, because winter is coming, and already we are seeing a pressure in the summer that we perhaps haven't seen in previous years. We know our staff are working extremely hard. We know that there are a lot of patients attending A&E departments, a lot of patients being admitted. This is not about the NHS simply slipping away from what it used to do. This is about an increasing and justified need for patients for these services as you so rightly pointed out, as we live longer and patients have more need for services. And the numbers of patients turning up at our A&E departments and being admitted gets greater every year. So we're working with the system resilience groups, which are the groups that I mentioned earlier, where all the organisations on the front line around a health economy, health and local social care economy come together. The system resilience groups have been planning exactly how they will put in place all the range of things that will take the pressure off the A&E departments and make the A&E departments themselves and the hospitals more slick, more able to get patients discharged when they need to be, more able to get patients treated to reduce the number of bed days. We have, as reported to the board last time, put significant amount of additional funding into urgent care, and we've currently just received all the system resilience groups reports, which we will be assuring, taking the best learning from one, transferring it to others, to assure that the plans are in place for winter that we need to make sure that the pressure comes off this barometer of the A&E department. At the same time, we've put significant additional funding into the system in order to buy more planned care activity, more activity for patients waiting for operations. And again, the system resilience groups are working with local hospitals, with local CCGs, with local social care, to identify exactly what extra operations could be done, particularly over the summer months, and particularly over the summer months when we know there isn't such demand for urgent care. How can we turn our hospitals' attention both within our NHS trusts and within the independent sector, who often have a lot to offer in terms of extra diagnostics and elective care, to make sure that we can continue through the winter when things are busier with urgent care, we can continue to meet the standard that we've set ourselves, that 90% of patients who need to have an intervention, an operation, or something that admits them to hospital, at 90% of them will have that intervention, will have their treatment completed within 18 weeks from the time that they've been referred to the GP. So again, really important to understand that's the whole, that's not 18 weeks waiting to be seen at the hospital, that's 18 weeks from when you were referred to your treatment being started. And underpinning that, of course, are the important standards around diagnostics, that patients should only wait 6 weeks for a diagnostic test, and the important and accelerated times for patients who are waiting for cancer. So again, the plans for that extra activity is underway. All our hospitals have been doing extra lists across a range of specialties in order to put them in the best possible position for the winter. Much of this work work, of course, is predicated, as Simon rightly pointed out, on partnership, and the increased focus and emphasis on the tripartite arrangements that I've already mentioned, so I won't repeat, at both local and national level, will be just so absolutely vital for delivering this for patients. And it isn't just we talk about the tripartite arrangement across ourselves, TDA and Monitor. I do want to emphasise that that arrangement extends to local government association at national level, and at local level that arrangement absolutely extends to working with the local authority and those that deliver social care, because the intimate relationship between social care services and what's going on in our health system, as well as the impact it has for patients, is so vital. So a whole range of things going on there, and as I say, this is to give the board assurance that we are giving this very significant attention, and to outline some of the things we're doing to make sure that we can, and are confident that we can, continue to provide a really great service for our patients in the NHS as we move forward into winter in difficult times, in difficult circumstances.
Thank you. You mentioned Bruce's urgent and emergency care review. May I invite you to comment on that?
Thank you. I think Barbara's given a very good summary of the kind of difficult circumstances which prevail at the moment. But we do have a longer-term strategy for dealing with some of the problems which relate to urgent and emergency care. I mean, the reality is that many people go to A&Es because the lights are on and they'll be seen quickly. Indeed, the average waiting time in this country in A&E is only 50 minutes. So people can get a solution quickly. And yet in other aspects of society, things are changing. People seek to help themselves more through a variety of different ways. So we're looking to improve the digital offering, if you like, to these patients at one level. The second thing is we want to increase the utility of pharmacy to people who need help. We have 400 million contacts with pharmacy every year, and a relatively small proportion of change there will result in quite a big change elsewhere in the system. We want to make it easier for people who feel that they have an urgent condition, and it's whether the patient thinks it's urgent or not that's really important in the first instance, that they can see their GPs more quickly. And we're working on ways of trying to accelerate progress in that area. But that would add to about 300 million visits to GPs a year. And then the next area that we're looking at is that at the moment we reckon that of people who call an ambulance, about 50% in some cases of the conditions that people call for could be treated at home. You know, it may simply be that they require some suturing, it may be that they require a recatheterization, it may be that they simply require some advice from somewhere else in the system. And we are using our ambulance drivers, our ambulance staff, who are really absolute professionals. You know, we trust them with our lives when we're in extremis. And yet we often confine them just to being drivers, transporting people from one place to another. So there's much more we can do to enhance that. And then about 20 million people show up a year in our A&Es, and about 30% of those people end up being admitted. So if we can reduce the number of people that attend A&Es, we free up time for those people working in A&E to deal with the sicker patients. And that would make a major contribution. But equally, if we put those earlier steps in place, we think that we can reduce the number of people who attend A&E who might otherwise be admitted. There's no doubt that if you're in your 80s and you show up at A&E, particularly if it's towards the end of the day where people don't have proper information on you, there's a very high chance that you'll be admitted. So we think that by improving the upstream offer, if you like, that we can not only reduce attendance at A&Es, but reduce admissions as well. And then, of course, Barbara's already alluded to the work related to the Better Care Fund, which we hope will result in much greater joined-up care between some NHS services and social and community services, which will enable us to get people out of hospital quicker. Once you're admitted, particularly if you're elderly, you tend to be there for a few days. So it's better not to be admitted in the first place. There's a much better deal that we can offer by keeping people at home safely. So we have a strategic vision for this, and we have a number of work streams to address some of these issues over the course of the coming year, and I'll bring that back to the board.
Thank you very much. Let me take some questions and comments from the board. Victor.
just want to ask about regional differences, whether this experience of A&E is experienced differently. Ah, right. Is that better? Yes. Anyway, can we? I'm interested in the regional differences and other regional responses. First question. Secondly, is there a match between the need for better care fund responses, the better care fund responses that we're getting from areas, and our perception of the need for joined up working? Is the quality of the approach to better care fund matching the need for better care? You see what I mean? In different areas. I mean, do we know that in any?
I'll probably answer the question in two parts if I can. Your first one on regional variation. I think it's much more than just regional variation. It's very local variation.
Well, yeah.
Actually, we produce statistics on the A&E standard as with the others very frequently, but the A&E standard on a regular and weekly basis. And if you look, you will see that the times patients are waiting at different hospitals is very different indeed. And the hospitals are at the centre of the system resilience group, so the kind of geographies on which patients work. But actually, for the most part, what we find is that that maps onto local authority boundaries. So our system resilience groups and health and wellbeing boards, they have a lot of commonality. Sometimes there are one on two, but actually it isn't that they're doing two completely different approaches, which is really important. So we specifically targeted those system resilience groups, those patches where we have the most concern about the A&E performance. And of course, what we're trying to do is to get everybody up and above the standard, but some have a very long way to go, and therefore kind of working with them and producing for them a reasonable target and a reasonable timeline to get back on place for back to time for their patients is really important. In terms of the Better Care Fund and how we're assessing that, I think, as we do with everything, you kind of have to look at the environment in which people operate and the capability and capacity of the team operating there. And I think we've got a lot of lessons to learn from the CCG authorisation process and assurance process that has ensued. So what we do see with better care plans is that we have some better care plans which are absolutely excellent, and not surprisingly they are coming from areas where there's a strong track record of delivery. There is our soft intelligence demonstrates to us that there is great leadership in both health and social care. And possibly even the circumstances in which they operate aren't as difficult, because we have to look across the financial circumstances that both the CCGs, the commissioners find themselves in, the circumstances of the provider trusts and the circumstances of local authority. So what we're trying to do when we're looking at the Better Care Funds and the plans is identify not only how good are the plans, but also what is our confidence level in the teams that will be delivering those plans, and also an understanding of the challenges that they're facing, because actually if the challenges are greater, you need a better plan, I'm afraid, because we should not accept lower standards, but we need a better plan, and the chances are that those areas will need a lot more support to do what we need them to do.
Okay.
Before I move to part two, which is Paul's report, are there any other issues which arise for Barbara? Yes, I have Moira, Margaret and Kieran.
I just wanted to ask Tim actually about the Friends and Family test and when we might have the improved data, as it were.
So what we've, so the Friends and Family, we did a review of the Friends and Family test as we said we would, and that review concluded that in its first year of existence, it's proved to be a very powerful tool for local improvement in services, but also potentially a very important component of the choice offer that we want to make to the public and patients, and in that context also an important driver of improvement. But we did also reflect that there were a number of things that we felt could be improved about the way it was being administered, and the most important of those was the fact that the way it's actually published was not proving as accessible to the public as we'd hoped. So we're now going to be publishing it, and indeed are already publishing it, as a percentage rather than its former format. So the data there's been no discontinuity in the data, and I think the point of this note was simply to say that we've done that review, that the data is now being presented in a different way, but it is still being published as we speak.
Could I just, I think the board would be very interested to see that review. I mean, we're really interested in the way in which the Friends and Family Test has been working, and I think if you wouldn't mind circulating it, that would be welcome. Margaret.
My question's really allied to the Friends and Family review, and it was really just to find out from Jane whether what action's being taken on the maternity results of Friends and Family. There seem to be a significant number of women who are not experiencing quite the sort of level of satisfaction that one would have hoped.
Well, hopefully you can most of the work is being done locally. However, we also have a maternity programme board that we've established, and one of the key elements of that is looking at the patient experience. And the positive thing about the maternity Friends and Family is that we ask the question at various different stages throughout both pregnancy and delivery and postnatally. And I think that's able to give local organisations, local maternity units, quite a lot of very good data and very good information about what they need to change there. One of the priorities that we're looking at is the ability for women to have a named midwife during pregnancy, particularly, so that there is a continuity of care, and that often is something that women find really, really important. And then from a postnatal point of view, the other part of the work we're doing is concentrating on significantly on increasing the number of health visitors that we have, so that there is very good care for women after they've had a baby, and they're able to to learn how to look after them, what to do, and particularly picking up any maternal mental health issues, which is something that is an absolute priority. Alongside that, we've also got not very large, but some small teams that work in regions that are actually able to work with local organisations, local commissioners, local providers that actually identify any particular issues or trends. And as we get more data, more information, we'll start to be able to do that work more locally with those individuals.
That's really helpful, thank you. And with regard to the mental health issues that arise, will we get figures on the findings and how those are dealt with?
We've identified 6 high impact actions that we want the new health visitor workforce, as it were, to concentrate on. And as part of that, mental health is one of them. One of the things we're looking at doing, and we're working with Health Education England and the Department of Health on that, is providing additional training and education for the newly qualified and existing health visitors around how to look for perinatal mental health issues and what to do about that. So we can feed that back as we get more information.
Thank you.
I've got a picture of the mandate in my head and the outcomes, and I think, Bruce, what you were saying, it's a really good coherent plan. Tick domain 3. 4 of us around the table were at a brilliant presentation by Matthew Fagg on premature mortality. Can we aspire to an equivalent coherent plan to address domain 1 in the same way?
Yes, we can. But it will inevitably be more fragmented. And the reason for that's quite simple. People die from all sorts of reasons. But what we do know is that there are 5 big killers in the following order. Number 1, heart attack. Number 2, stroke. Number 3, cancer. Number 4, respiratory disease. Number 5, liver disease. And then there's a bit of a gap in terms of the proportion of people who die from those. And so we have plans in place for addressing each of those. The issue that we have is, of course, the remaining areas cover still a significant proportion of the population, and mental health would be an example. So whilst intellectually we can have an approach for each and every one of those that is pretty coherent, We've still got some work to do in a way that we can tackle the whole problem across the board. But what I'd invite you to do is to bear in mind that people die from different things in different parts of the country. So in some parts of the country, cardiovascular disease is a big deal. In others, respiratory disease is a big deal. And in some parts, like migrant communities, TB could be an issue, for example. So we need to leave it to local clinical commissioning groups and health and well-being boards through their strategic needs assessment to work out where the big gains in terms of mortality lie for them. But what we can do is we can help them with that analysis. We have tools to help them to understand where the big variations in mortality lie. But there's an issue here about the relationship, if you like, between us and those who are commissioning services locally.
The one thing I'd add, though, is one of the things that came across very strongly in that presentation is that there are some things which nationally we're not good at, which they're in that list of others, but if we don't take a collective view, they will never appear in any one geography. Maybe we can pick it up later.
Well, I'm just to add to what you're saying, Kieran, and build on Bruce. I mean, I think we're going to, as part of this 5-year process, but beyond that, actually get a lot tighter about saying here are 5 or 6 big things that we need to work on in a more concerted way. In respect of cancer, we know that it's early diagnosis to improve 1-year survival rates as one marker of success. We've seen a 19% increase in urgent cancer referrals in the course of the last year on the back of some of the public health campaigns that will help with that. But we need a game plan for cancer outcomes improvement, as we do in some of the other big areas that Bruce talked about. And above and beyond that, I think we're all keen that the NHS begins to talk about some of the broader determinants of outcomes and prevention, and we started doing that around obesity. We started having a conversation about the role of other actors in the economy and society, including employers, the responsibilities that local authorities can have to drive regulatory or other changes in the food industry, and so forth. So I think this is so important for the NHS and for the people who are here. So we've got to be getting into those debates rather than just assuming that others will have that conversation without us.
Yeah, the one I had in my head was premature mortality for children as well. It only comes up when you look at the national stats and compare internationally, and it's just making sure we don't lose some of that stuff through the analytical capability we have, because we are a national health service.
Indeed, we've done some work on that, which we can dust off and share with you, because you're absolutely right. Whenever you have discussions about burden of disease, whether it's burden by mortality, burden by morbidity, or burden by economics, or burden in terms of inequalities, children don't quite get in there. And to be fair, we had a group that looked at all of this, trying to coordinate it, because I was keen that we had a robust methodology for prioritising the areas that we looked at. And Ian Kennedy was on that group, and he was absolutely, I can't think of the right word, but he kept reminding us, don't forget children, because there is a risk. And in fact, when we look at the outcomes framework, what we're looking at, the measure that we use is potential life years lost to individuals or to society. And that forces us back into the territory of children, because if we lose children, we lose a lot of life years, and we lose a lot to the individual, to the family, to the economy, and to society. So that's the methodology that we're alighting on to try and ensure that we don't forget certain groups.
Okay, thanks, makes sense.
Okay, thank you. May I at this stage move on to part 2 of the assurance report and invite Paul to talk to us about finance?
Thank you, Malcolm. I'll try not to make a link between premature death and the finance report. So page 3 gives you the outline of what's happened in finances at month 4, which obviously takes us through to the end of July. By the quirks of meeting dates, I get all the answers for month 5 on Monday, which is deeply frustrating, but advanced intelligence suggests it won't tell me anything very significantly different from what you have in front of you. Much more importantly, though, given the limitations of what you can extrapolate from information from the early part of the year, at month 6 we always do what we call a deep dive, which is essentially to go through at all the levels of the organisation, the risks inherent in the year-to-date performance and the forecasts in quite a bit more analytical detail than we do on a kind of month-by-month basis. So by the end of October, early part of November, we will have a much better picture, I think, of the emerging risk profile and what, if any, corrective action is required. So enjoy these numbers you see here with a degree of caution at this stage, I would say. Just to draw your attention to paragraph 9 and, if you like, the conclusion of it, which takes me back to last night's presentation, just a reminder of the context, which is that we enter the year with a surplus of more than 800 million. Those of you who spent the last week sort of glued to your calculator trying to work out how the numbers at the end of paragraph 9 work. I'm mortified to say there is a typo, which is why you have done so. In fact, we brought in 867, not 837 into the year, which is why the numbers work when you do that. But the important message, other than the typo in that, is that we plan with the Department of Health to consume 400 million or thereabouts of the brought forward surplus this year. And indeed, the same facility is available to us next year. As I said last night, there's only so many times you can consume the same amount of money, and therefore the dynamic of that clearly is what the 5-year planning that we talked about is designed to deal with. So, coming back to the numbers, the year-to-date and forecast numbers, as you can see here, are marginally positive overall, but you can see from the percentages, I couldn't even get it to register on the scale. When you look at the forecast, it's 0.0%, but it happens to be 15 million positive. Within that, there are very few moving parts in the month 4 forecast, slight deterioration in a couple of CCGs in the Midlands and East for very specific local reasons, slight improvement, interestingly, in the specialised commissioning position in the Midlands and East, and then the odd movement in IT projects in the central programmes, but nothing that I would draw to your attention as particularly significant. Possibly more significantly, if you look at the QIP report, which is at the back of the appendices here, you'll see QIP being the savings programmes that commissioners run. The positive spin on it would be that we're doing significantly better than last year. So cumulatively and forecast-wise, we are at about 95% of the actually higher level of QIP aspiration that we set for this year than last year, which gives us, I think, an expectation of exceeding last year's delivery on QIP. However, as I say, forecast to be enjoyed with some degree of caution. I have pointed out at paragraph 12, and I do think this is important for the board to understand, the risks which attach to even delivering that 400 million reduction in surplus that I started off with. As you know, we do every month, whether we're doing a deep dive or not, a full risks and opportunities, risks and mitigations analysis, which is a combination of the work that every CCG in the country and every area team in the country does to assess its own local risks and mitigations, and overlaid upon that then the judgment of my team and others that we work with on bigger kind of national risks, if you like, that attach to that. And I've drawn to your attention there that the risks run to something like 400 million pounds, which clearly, if you're aiming for a surplus of 400 and a bit million pounds, is quite an uncomfortable level of risk to be carrying. As you'd expect from everything we've talked about in months gone by, and indeed my analysis last night of the results in 13-14, the biggest risk by a long margin is the specialised commissioning portfolio. When we discussed the plans for this year, you'll remember we talked about a 3% expectation of cost growth after QIP. That's significantly lower than the level of cost increase that we had last year, and therefore assumes the success of the 7-point plan which the specialised commissioning teams around the country are implementing to improve the level of efficiency, to improve the grip on activity and all the rest of it. Clearly that carries with it a delivery risk which we'll start to see either positive news against or indeed those risks coming in over the next couple of months. And the particular factor within that then is the Cancer Drugs Fund, which of course Simon mentioned earlier, where we've got additional budget in, but even getting to that level of budget is going to take some doing. At the moment, CCGs are reporting that they've got broadly as much mitigation as they've got risk. So there's upsides and downsides. I think as we look at the emerging picture on both referrals and on emergency admissions, which we've referred to a couple of times this morning, it remains to be seen whether that trend as it goes through the year will remain quite as positive as that. I think there are probably more risks in that than than is currently being reflected. The other big factor in this we've talked about as well is the continuing healthcare legacy provisions and the estimate we had to put into the plan for this year, which was £250 million. There is a risk against that it will be a higher level, and we are obviously committed to working our way through those legacy claims at the pace that we can, and we'll see whether that leads to further challenges. A few other small ones, but those are the main things. As you know, unlike last year, we weren't able to hold back significant reserves against those sorts of risks. So as we go through the deep dive over the next month, we will need to look very, very carefully at which of those risks are materialising, and then we will have to be quite speedy about bringing in corrective action if that turns out to be necessary. So that's the Commissioner view. Everything I've talked about so far is purely the combination of CCGs and area teams and indeed the central programmes that we run, broadly neutral in forecast. The risk profile I've drawn to your attention. It will not have escaped your attention that there is quite a bit of news around in the system at the moment about the difficulties in the provider sector, in both the NHS trusts and perhaps slightly more new, as it were, in the profile in the foundation trusts that are under Monitor's direct supervision. Clearly, all of those facets of the pressure that's in the system. I mentioned it last night that it was clearly present in 13-14. In 14-15 we had the most difficult planning round on all aspects of the system, and I think we're starting to see some of those pressures coming through in the providers as well as the risks that I've talked about in commissioners, all of which means that when we come to our 15-16 plans, which we talked about earlier, getting that balance of financial risk and mitigations right is going to be very, very taxing both for commissioners and for providers. That's really all I wanted to say by way of report at this stage. Next board report will probably be slightly more exciting.
Well, that wasn't exactly dull, Paul. Thank you for the report. Let me ask if there are any questions that members of the board would wish to raise with Paul. No, thank you. That was a very comprehensive report. I'm very grateful. Our function as a board in relation to this item of business is to receive these reports, but also to satisfy ourselves with assurance that on the NHS performance, the constitutional requirements are being met and patients' expectations are either being met or we are assured that plans and steps are in hand which will allow us continually to improve performance. Are you happy to accept the business on that basis? Good. Thank you very much.